Well, welcome to another webinar with Grow Dental Education. Today's topic we're going to be discussing is bisphosphonate and a physiology update. The reason this topic was chosen, there have been some new developments, you might say, with the subject of bisphosphonates, particularly relating to BRON, bisphosphonate-related osteonecrosis. And this is Dr. Witherspoon. I'm Jennifer, and we're going to get started, and we just want to share what's out there because we think it's quite a bit of interest.
So actually, Jennifer, we're going to review an article that was in the General Dentistry in August of this year by Dr. Doug Dam and his friend Dr. Jones, and we're wanting to review it so that we think it's pertinent information that people should know. It's our view of the article. We try to present it in an authentic way, but we're going to try to present the material so that the clinician himself can get something from it. So it's actually a review of his article.
And what kind of developments has Dr. Dam is he sharing with us?
Dr. Dam's article is called Bisphosphonate-Related Osteonecrosis of the Jaws, a Potential Alternative to Drug Holidays. So let's talk about the way that we have treated it before. And in this instance, remember we're dealing with the osteoporosis group, the oral manifestation of the medication, rather than the IV group, which we've concentrated on before. So it has a little bit different approach.
Yes, and that's really where the idea of drug holidays came from, and encouraged by the ADA. The patient population that was primarily focused on was the population that were cancer patients and were receiving IV therapy. So this population is a completely different population. The standard of care that was promoted in that population really is kind of missing the mark with this population. So this is the patient that either has osteonecrosis or has osteopenia, so their skeleton is at risk for fracture, and how this drug interplays in that, particularly when they need or have the desire for oral surgery. Well, that's the patient that we're looking at.
So it's a common disease that's treated in a common manner, and we get some oral complications that we're wanting to deal with in this. That's yes. What we're trying to review here.
Yes.
And so it was Dr. Dam's idea, and he gave this in a lecture here this last year, and many of them, that we find a potential alternative to the present approach, and maybe we can do it very safely. So that's our history of the thing.
So let's look at some facts. Why is this patient population of particular interest to us? Here are some statistics for you. 10 million people in the U.S. are currently diagnosed with osteoporosis, with an additional 18 million at risk. So we're talking U.S. only here.
Right.
10 million with osteoporosis, 18 million at risk, which would include part of that osteopenia group. So that's a significant number. You no doubt have a patient in your office that has that diagnosis.
Can I add another thing? And actually, the osteopenia group would add another 34 million to the group if we can consider it. It's not just all that. So it's a huge group of people. Worldwide, we're talking about a huge population. And then the problem is the difficulty that these people have with their skeletal fractures. That's what the physician is looking for to treat. First of all, we might define what osteoporosis is. It's a common metabolic bone disease that the skeletal remain. You have a low bone mass, and you have a low fragility of the bone themselves.
Okay.
So that in itself is what we're defining.
So this is a profile, which we'll get to later in the webinar today, but there are specific numbers that define whether the patient is diagnosed with osteopenia or diagnosed with osteoporosis.
Can we give a few more statistics to show the importance of this thing? It's a global problem. It's not just a U.S. problem. It's worldwide. And the problem is the fractures that occur from it. It's estimated that there's going to be 1.5 million fractures that are going to be due to osteoporosis each year. 350,000 of those are hip fractures. Now, that sounds like that is a lot of hip fracture, but the problem is, let's talk about the statistic. 5 to 15% of the non-treated individuals with osteoporosis are going to develop fractures. 15 to 20% of women and 30% of men are not going to survive a hip fracture. Now think of that. 70% of the hip fracture victims never regain full function in the ordinary sense of the word. So it's a critical element for these people.
Absolutely. So we're looking at this patient on a bigger scale, not just their oral health, but really if we get into a hip fracture situation, the statistics are really poor as to quality of life and even survival. So in dentistry, we don't want to do anything to compound that possibility.
And that's what we're going to discuss today. Some of the ways that this occurs and some of the ways that we might alter the treatment to be
Okay.
helpful. And we started out with the drug holiday, and I think you mentioned about, informally, we were talking about the IV group mostly, but the idea was that we would get a holiday before we did surgery, we'd give a holiday afterwards. But these people who have critical osteoporosis can't tolerate that. Their skeletal mass is not of sufficient quality and quantity to allow them to undergo these things. And this is the group that we're particularly interested in.
In fact, the risk is so great that the risk of BRON, we'll call it, B-R-O-N, is less substantial than that of that, protecting that skeleton.
It's the protection of the skeleton that the physician is after, the prevention of the fracture. BRON just happened to come along as a discovery of the treatment, and we're going to point out as we go along how this occurs. And then, of course, we originally, these cases were brought up, started in 2003. Dr. Marks and Ruggiero found those early cases, and as we gathered information, oral surgeons all over the world found they were getting cases. We had our first case about 2005, and these are debilitating, some of them very debilitating cases, but compared to the problem that the osteoporotic individual has, it wanes, and the medicine does a good job.
So in an ideal world, which maybe we can create, that's the excitement here, can we protect that osteoporotic individual and significantly reduce the opportunity for BRON to enter into the picture? Can we meet in the middle? And that's what we want to share with you today.
Can we talk a little bit about BRON etiology?
Yes.
You know, it appears to it's a result of, and we're going to call this amino resorptive agents, the bisphosphonate. So henceforth we'll get that as a classification. This group appears to have some sort of anti-osteoclastic activity, either a decrease in the number of osteoclasts, decrease in the function of the osteoclast. It interferes with the angiogenesis that goes on with it, that supports it, but it interferes with another very critical thing that we didn't pick up in the beginning, which is it interferes with the bone remodeling. That's where we get in the trouble from the dental standpoint.
So we really need to look at, to cover this topic thoroughly, we need to look at how bisphosphonates work, their mechanism of action, the pharmacology, as well as a little review on standard bone remodeling. Something exciting that we've learned, at least in the last few years, that exists that wasn't really there when we went through those college courses, that's new. And then, in the treatment plan, how we can use all of that information to incorporate to give our patient the best outcome.
So our object is to add to the knowledge field in some way or other, and piece by piece, maybe we can figure this thing out. Why don't we start in with a post-surgical review? If we took out a tooth, for instance, we had some sort of an insult, or we put in an implant, what happens in the ordinary sense? What's our ordinary healing process? So we'll go through it. There's 4 steps to it. The first is, of course, the clot formation, where we have an influx of, after the disturbance, we have an influx of the blood, and we get a hematoma. The vascular system begins to work. The angiogenesis starts to work. We get a clot formation. that starts the healing process. Second phase is the inflammatory phase. Now, we're going back to the inflammatory phase. We remove the bacteria and any form of debris, and remember extravasation of the fluids, which does this. We clean up the area. Then they start the formation of granulation tissues. The cellular elements begin to change, and so this is kind of an orchestrated thing in which the tissue becomes granulation. And after that, then of course collagen is formed, which forms our good stable base for it. Third step then is the formation of woven bone, the first step in the process. And the fourth step then is the transformation of that woven bone, which we'll consider as an immature bone, to a mature bone, and we'll call that lamellar bone. And this takes place, as we're learning now, by the BMU, which is a wandering team of cells that dissolves old bone and forms new bone. And it has a very interesting research that we went on to point out. And this is where we get interference with the drugs that are used in the treatment of osteoporosis. Jennifer, let's go ahead and talk about the bone remodeling, since this is an area of the physiology, bone physiology, that is really very interesting, and we are learning a lot about, and we're learning where the drug actually has its problems in these patients.
So let me ask if I understand correctly. So the new bone is different than what we're talking about. Once we have that healing process, get through the new bone,
Right.
we don't arrive at lamellar bone
Right.
for about 4 months.
Right, that is right. Okay.
Then it's the lamellar bone that we're really interested in.
It's a
with
mature
this
bone.
unit
Right.
that's
It's,
going to come through.
Right. The unit that comes through takes the woven bone, and it's like a spear, and it interacts. There's numerous ones of these little spears. They're little phalanx, which sticks out, as you can see in the drawing here, has the osteoclast out in front of it. Then we have the osteoblasts that are forming the new bone, and then there's new bone forming above. And as they get incorporated, the osteoblast becomes incorporated in the bone, then it becomes an osteocyte. And the life cells of these cells is much different. So that's the main, it's sort of there's numerous ones of these things that are going. So it requires an osteoclast, the osteocyte, the osteoblast, as well as the angiogenesis, the fluids that go with it to make the whole thing. It's a complicated orchestration that goes on constantly in bone. Bone is in a state of flux. It's being torn down, rebuilt continuously, no matter what part of the body we're talking about. The particular interest here with the drug, as we'll point out in the pharmacokinetics of it, is that it affects the areas of bone that are under most metabolic development. In other words, those that are injured, for instance, would be an area of high metabolic concentration of the osteocytes, and that's where we have the problem.
So we've known about osteoblasts, osteoclasts, and osteocytes for a long time.
Right.
It's this BMU, this unit, how they orchestrate together,
Right.
that's of interest. Some articles refer to it as a cone that moves through, and at different angles,
Right.
multiple cones interweaving to turn this woven bone into lamellar bone.
And the difference is, if that doesn't occur, then you have remaining immature bone, which on a radiograph would show up as a radiolucent area. You know that it is not complete. So the difference that occurs here in this instance is between the woven bone being the immature bone being changed into mature bone, or the lamellar bone.
So these different components have different life cycles, and when we review that, we realize that now we're kind of in a mathematical equation as to how to figure out the interaction with this drug. So as a review, osteoclasts last about 2 weeks. Osteoblasts' life cycle is 1 to 3 months. And then osteocytes, we don't really know, years to decades. The only thing that determines their lifespan is really when we come back through and remodel again.
Right.
So depending on when that happens, that dictates the life of our osteocyte. But the human skeleton, just as a general understanding, we can use 4 months kind of as a blanket calculation of how long that remodeling period takes
place. Actually, and research is showing that it takes an average of anywhere from 2 to 8 months, but we give an average of 4 months. So when we're thinking about altering our drug therapy, then that comes into play. Because if we know that we're going to have a certain amount of bone remodeling to take place, and if we have a drug that affects the osteocytes, osteoclasts that actually affect the change of the woven bone to lamellar bone, then we know we've got a problem.
So we've covered, just as a review, the bone and the life cycles and that unit, that BMU unit. Now let's go to the other side of the picture and review bisphosphonates
Right.
and the pharmacokinetics of that drug, and then we'll put it all together.
Right. If you look at this the little drawing here that we can't show this drawing, but
We'll put it on the screen.
we
for
need to put it on.
everyone. Yeah.
On this drawing that Jennifer made, this is just a drawing to show how the bisphosphonate, the amino resorptive agent, which is what we call the bisphosphonates, because there's another group that is coming along that acts in a different manner that may be substituted, how this group acts on everything. If you look at the diagram, you'll see that 50% of any ingested, whether it's with an IV medication, whether it's oral medication, or whether it's the remodeling process, which is producing it, no matter what the process, 50% of it is going to be excreted by the kidneys almost immediately. At least within the first 2-week period, it's gone.
Okay.
The other 50% then goes to bone, and there's a different affinity for the various cellular elements. The osteoclast has about an 8-time affinity for it. In other words, it's drawn to it. The osteoblast has about a 4 times. The osteocyte really has a very low affinity. And this is where you separate the advantage of the drug and the disadvantages of the drug. The advantages are that if you think about bone, 85% of our bone is resting bone, not doing anything. 2% is going to be resorbing, tearing down bone. The remaining 10 or 12% is going to be reformation of the bone. So most of the bones in our body at any one time are at rest. And therefore, this drug itself, there's a very low affinity for the cellular elements in resting bone. The osteocyte doesn't have much of an affinity for drawing it. It's drawn, the drug is drawn to the area of highly remodeled bone, where remodeling is going on.
Which is a really interesting point. I just want to pull out that this medication is not evil. This is a fantastic medication that works perfectly as it was designed. It's only when we introduce a surgical site into it that now we get, which will explain all of this dumping of medication that sets us up for necrosis. So the drug itself works perfectly as it was designed. Right. It's just how do we work with this drug in a surgical site.
Well, let's go ahead with this drawing. So you see the little group there to the left, the osteoclasts, the time they have the 8 times affinity, which are resorbing bone, tearing it up. And then we have over to the right of those the osteoblasts, which are forming new bone. And then as they become embedded in bone at the far right-hand side, we have the osteocyte. The osteocyte it's in the resting bone, so it doesn't need the drug. It's drawn to the area that needs to be resorbed. Now then, as this process goes on, which is also going on constantly, we have another division. Half of it is excreted immediately, and the other half is put back in the serum and is circulated, and you're undergoing the same process. So it's kind of a ever-ending cycle. So that's why the drug itself has a long half-life, at least a 10 or 12-year half-life.
Which is truly incredible to think that a drug would stay in the body for that period of time.
Now the negative effect, you gave the positive effect, which is it works beautifully, and it solves great problems. And BRON is an insignificant problem in most instances compared to the results that we're getting. However, it is significant for those who have it and can be very, very detrimental to them. There are 4 things that the agent, how it acts and what it does. Number 1, it reduces the number of osteoclasts, the number of them. The affinity of the drug is drawn to them, it reduces them. It makes it so that the cellular elements that they come from, the stem cells, do not differentiate. So we do have a lower number of osteoclasts. So the resorbing process that goes on constantly in our body can't go on. That's number one. It then also does another thing. As the concentration of the drug increases in that area, it produces, as we call it, suicide for the osteoclast, apoptosis. There's so much of the drug that it dies. It's so we reduce the number, many of them die. Then it also blocks the angiogenesis that goes on, which is
And that angiogenesis is so
it's
critical.
so critical.
If you don't
Right.
have blood flow, then you can absolutely see war
Right.
necrosis. There.
None of the cellular
That's it.
elements that change are going to occur. The growth factors aren't there to make the changes, and so it's kaput. So everything is off. So
Right.
that's why we get the necrosis of the bone. It's going to occur.
And Dr. Witherspoon, I'd like to interrupt you just
Okay.
for a moment because I want to put a little disclaimer out for that drawing
Drawing?
that you're seeing
Oh, yeah.
or have seen, because we couldn't find one that really showed what we wanted to in a manner that we wanted to show it. And so we just went to the rescue, got some highlighters and a pen, and just put it to paper. So just a disclaimer on that.
Right. Well, and to tell you a little bit more about that, we drew it on our board in our office.
Yes.
So we could understand it and have a clear picture. And I really think it tells the whole story. If you just look at it, there's what the drug does, there's the cellular elements that it affects, and you can draw your own conclusions as to why it affects.
And with such a serious topic,
Yeah.
got a little humor in there.
Yeah, a little humor there. All right. Okay, shall we go on to the next part? Oh,
Yes.
I do want to point out one thing. The distribution of the NBP, the bisphosphonate, is not uniform. It has certain affinities, as I say, certain cellular affinities. It goes to the area of remodeling, high metabolic activity. So that makes the whole difference in it.
Yes.
If it were uniform, it would not. We would treat this in a much different way.
Yes, absolutely. So what would we consider a site?
A site would be an
surgical
extraction.
site
Surgical site would be an extraction
in
of
a
the tooth.
dental practice.
Or if you were going to put in an implant,
Okay.
just anything that was an insult to the bone is going to be a site in which you're going to have remodeling. And the remodeling is going to take a certain amount of time, and this agent is going to affect the remodeling. So the object here is to try to figure an alternative thing in the treatment of it so that people who have the disease, osteoporosis, or its predecessor, osteopenia, have a method to have surgery if it's absolutely necessary, and that occurs in many instances.
So these IV therapies, now that we've discussed kind of the life cycles of the different parts of this unit, the IV therapy we can work with because it's not a daily insult. It's once every 6 months or once a year. And so we have time to allow 2 months into it to really have most of that drug cleared out of the serum, plus another 4 months post-surgery to allow us to get to that lamellar bone stage. And so that gives us some space to work with, and that's kind of where that thought of drug holiday came from.
Right. Well, you brought out the whole point. It's the pre-surgical time, the element, how long, in theory, if you had no bisphosphonate circulating in the serum and you did an insult, you're probably going to make it all right as long as new bisphosphonate wasn't introduced in some manner.
Exactly.
So it's the pre-surgical and the post-surgical areas that we're interested in the time element, and that's how the drug holiday came in. And the ADA, very remarkably, came to a good conclusion in which they did not see that the drug holiday itself did the job that they were wanting in preventing the individual with osteoporosis to have continued bone mass loss or bone mass fragility.
Yes. So now we're getting to the meat.
Right.
What can we do as a possibility for this patient that has osteoporosis and osteopenia that comes into our office, and whether elective or in need of oral surgery? What can we do?
Okay, so that brings up another group of topics. Who are the people who are highest risk that we need to look at in this instance? This is the group of people that we're interested in. Okay, and this is the way that we think that you can be helped by it, and this is what the article by Dr. Dam suggests. Number one is we need to know the bone density. We know the mineral density, the BMD, and usually those are done at 2-year intervals in which we can tell the bone masses. Now it has some fallacy. So we then need to go to the next plan, which is called a DEX. It used to be called a DEXA, but DXA is what it's called now instead of the DEXA. And this is a dual energy X-ray absorptometry test that defines osteoporosis. It defines the degree of the osteoporosis. It measures it. It measures it against a normal. And you can tell whether it's osteoporosis or osteopenia. Then we can assess this group with an additional set of tools, which is called FRAX, F-R-A-X. This is set up in Sheffield, England, in which it is done online. It's historical because there are various things besides these elements that affect bone densities and so forth. And they determine then what your risk of having fractures is going to be. And then we go from there.
So we have a patient who comes into the office, diagnosis of osteoporosis.
Right.
There will be I lost it for a minute, a bone mineral density number somewhere in their history within probably the last couple of years that was done to give them that diagnosis. So if it's a negative 2.5 or greater, they're given the diagnosis of osteoporosis, more severe. If it is 1.0, negative 1.0 to negative 2.5, then they're given the diagnosis of osteopenia. Now, it's just understood that if a patient has the diagnosis of osteoporosis, true diagnosis, negative 2.5 or greater, that we can stop there because that risk is high and we can just move on to the next thought of what medications are we going to do or how are we going to change them. But if that patient has osteopenia instead, then we want to move on to that FRAX, which, as Dr. Witherspoon mentioned, is online. You can go online today. Anyone can take it.
Right.
It's a series of questions that help decide your risk. And what they're looking for is risk of fracture within the next 2 years, is it?
Well, it's 10 years or 20 years, depends on it. And it's greater than a 3% chance of fractures. Now remember, this is the thing that the physician is looking for to treat in the case of the osteoporotic individual. It's the fracture that we worry about because of all the sequelae that we pointed out in the very first part of this discussion. So that's the thing I want. So if it's less than, if your patient has a major risk, a 10-year risk of over 10 years, then we need to do something. They're going to be a risk, and we need to be very careful with that patient.
So that risk is considered 20% or greater for fracture within the next 10 years.
All right.
Or a 3% risk of hip fracture within the next 10 years.
Right.
So they would kind of be lumped into that osteoporosis category as far as we're concerned with treatment.
And actually, this is just a measure of the deviation from normal. They took the 20-year-old who's going to have the normal bone density, and we measure at 40 what is our bone density against the 20-year-old. And as an average, it's a deviation. Then we can predict whether we're going to have a problem or we're not going to have a problem, or the probabilities of us having a problem. And that's the thing that we're dealing with. Now, there's some other things that we point out that they're working on experimentally, that's genetic biomarkers.
Yes.
At the University of Pennsylvania, they have a study going on. We're looking for anything that tells us an individual is going to be a severe risk, because that one we want to be very careful with.
So there's some really good tools that we have available that we can use that are maybe outside of our dental realm, but are available to us to take the best care for that patient.
But I think it behooves us to realize that we need to get with the physician, and we need to know these things and to predict accurately what's going to be. It's not as simple as a simple decision.
No, it's not. But we have great guidelines to go
Great
by
guidelines.
now. Yeah. Here's another interesting thing about bisphosphonates is that the positive effects, remember we talked about it's not necessarily an evil drug, but the positive effects are seen early on.
Right.
And when we say early on, we're talking from beginning to year 5 of being on this medication. That's when it does the most good. But we've heard that saying, that more is not always better, and that's exactly the case with these bisphosphonates. Because after year 5, we get into a toxic level, and then we start seeing some really funky things occur in these patients.
Leg fractures, other things that occur because of continued accumulation of the drug because of its long half-life.
Yes. Yes.
This is a very interesting thing, and there's lots of studies that go on about that. Essentially, I think there's some take-home that you can get from this, the practitioner can. Number one, if you've taken an oral amino bisphosphonate for less than 3 years, your probabilities are that you're not going to have BRON. You're not going to get it. So you've got a 3-year window there in which you can get oral health to an optimum degree.
Mm-hmm.
Take care of the patient.
Mm-hmm.
After 3 years, or maybe after 5 years, we don't know the establishment because different research has put 3 years, some has put 5 years. But then from after the 3 or 4 year period, you need to take care of that patient. And you hope that you and the physician can collaborate on the treatment, and you know what may happen to them. So that's a good take home with it. From then on, then you can use the regular thoughts of treatment of the bisphosphonate necrosis. There's something to add to this thing, all right. People who are continued high risk, we're taking the people who are high risk. There's got to be a transition, and this is what we're looking for, a transition from the amino anti-resorptive agent, the bisphosphonate, to other agents. And there are some other agents, or there is another agent or two on the market, which we can look forward to in the future as maybe being helpful.
Yes, which is exciting,
Right.
and we want to discuss that. What we often see, though, is the patient that's put on one of these medications and they're left on it. It's kind of common for that to occur. So one good question to get in that health history is when that medication was started.
Right. And that's a very critical thing that we ought to get from the health history every time.
Yes.
Right.
So it's encouraged that after 5 years, if they're still at high risk, such as the patient that Dr. Witherspoon was describing, to switch them off of a bisphosphonate and put them onto one of these alternative therapies. So what do we have out there? What options do we even have for alternative therapy?
There are several alternatives. The one that comes to mind right away is Fortigol, which is a very interesting agent. It's an anabolic parathyroid hormone. It does not increase the number of BMUs. Now think of it, it does not decrease the number of BMUs as the bisphosphonates do. It increases the number and the survival of the osteoblasts, and it increases bone density without causing us a lot of necrosis problems.
Which is fascinating.
Right.
In fact, there have not been cases of
Sure.
BRON associated with Forteo, and that's Forteo, I believe.
Yeah.
Forteo. There's also another medication that's kind of exciting, is Prolia, Prolia, and it's an injection at 6-month intervals, and it's showing some promise as well.
Right. That is an interesting one. It does, it can slow down healing because it's at 6 months. Now remember, we got a remodeling process is 2 to 8 months. 4 months is an average. So if you did not take any of the drug for say 2 months before you did add the insult, you'd only have 4 months left for healing. You may get immature healing, but it still would be better than the original thing. So Prolia, and another one, XGEVA is another one of the anti-resorptive agents, but both of them are anti-resorptive agents, whereas the Forteo is not an anti-resorptive. It's the parathyroid hormone anabolic drug.
Very good. So, where should we start? Patient
All right.
walks in our office, where should we start?
Let's talk about the clinical approach to this thing. All
Okay.
right. And we drew up on the board another one of our drawings of an algorithm, since that's the way we think and do, as to how we would treat this patient.
I guess we're more visual.
Right, we're visual. All right. So what do we do? All right. The first thing we do is get the bone density test, right?
Okay.
All right. Then we do a DXA.
Okay.
All right. From the DXA, then, we can decide whether the patient and then do the fracs too, if it's an osteoporotic, where it's osteoporosis or osteopenia.
Yes.
All right, the two then will have different approaches. Let's talk about the osteoporotic individual.
Okay.
What can we do? How can we alter that treatment?
Okay.
All right, we could replace it with Reclass, Prolia, or Forteo. Might be a possibility. All of them have different ranges. Remember, the Forteo is a totally different product. The other two would be relegated because the Reclass is a yearly injectable individual in anti-resorptive agent, and the Prolia is a 6-month anti-resorptive agent. So, therefore, we could plan our operative procedure around this thing and this means and try to get the results. If it's go ahead.
So if this patient is high risk and they're on an oral bisphosphonate, what's an option? One option, take them off the oral bisphosphonate, put them on Prolia, and we can schedule the surgery around those injections. Since it's an every 6-month injection, we can wait 2 months, do the surgery, and then we have that 4-month window for healing and remodeling before the next injection.
And the reason I thought about the 2 months, you might give the mathematics of that, is that remember the osteoclast itself lives 2 weeks.
Yes.
And this would be 4 times the 2 weeks. 2 weeks might be enough, but we because of the half-life and the introduction of the agent and the resorptive process, then we say 2 months.
So those osteoclasts, remember, have the 8 times the affinity, so they really suck that medication into themselves. Once they pass it on to the osteoblast, it's kind of inert. But when those osteoclasts come through again, they stir it up, if you will, releasing half of it back into the serum. And so after 4 generations of those osteoclasts, then we can pretty much guarantee that the amount of bisphosphonate circulating in the serum is very minimal. So that's why we like that 4 generations to go through before we start doing a surgery. So that's option 1. We have Prolia. Option 2, we can replace that BP with Forteo, and this is a great area if you have a high interest in this topic, is to do a little more digging on Forteo. But we were nothing but impressed about what we could find. Like you said, it creates significant new bone growth, which isn't wonderful in a surgical site. And it shortens the healing time, and it has not been associated with, as to date, osteonecrosis. So it sounds like a really good option.
And it increases the bone density, which is what you're after to start with.
Exactly.
All right. Okay.
Or a third option, if they're on an oral BP, is to flip them to Reclass, once a year injection. I should say infusion, not injection.
Right. Thank you.
And then we can time again the surgical procedure around that, waiting 2 months after the annual infusion to do our surgical procedure, and then we have a whole complete 8 months after before the next infusion. That would give us
Actually,
10 months.
10 months, yeah.
Let's go another. Let's add another 2
So
onto that.
you've exceeded the healing time.
Exactly.
Right. So bone remodeling should occur.
So you have 2 or 3 great options. You have switching them to Prolia, Forteo, or Reclass. Now, what if that patient is really not in the osteoporosis category, the high-risk category, but what if they're more in the osteopenia category?
So we run the fracs, the test that's going to determine their percent of the possibility of fraction.
Okay.
And if it falls within our guidelines, it's going to be, if it's greater than 20% possibility, less than 20%, we're going to stop the bisphosphonate. Okay. Which means they don't really need it. Okay. If it's less than 20%, then we're going to again go to the 2 ways, either the Prolia, the Forteo, or the Reclass. So we have that alternative again with that group. So the only addition is that we added the fracs to it to determine the risk of the fracture.
So an osteoporotic patient doesn't need the fracs. Their risk is considered high, and we're going to look at these 3 alternatives. If they're osteopenic, we want to know how severe it is. If it is severe, according to that FRAX, then we're going to treat them as osteoporosis and put them on one of those alternative therapies. If they're not considered severe by that FRAX assessment, then we can look into just stopping the medication, period. So it really depends on what that bone density is, and then do we need to do FRAX or not, and then do we even need the medication? So it really depends on where that patient's at and their risk, because brawn is less of a risk than those high-risk osteoporotic patients.
I think that there's an essence that we ought to think about here, and when we think of this whole thing, if the serum itself is clear of the amino bisphosphonate at the time that you do the insult, the extraction or the placement of the implant, and has been cleared for a period of, say, 2 months, and you keep it clear for the period of the bone remodeling, we should be able to get through without the severe complication. That's the theory of it. Now, it's obvious that what Dr. Dam is trying to do here is to stimulate research along this line. Theory is not always an absolute. So we want to stimulate the action because this should work in this manner. It isn't meant to be defined as a definitive approach at the present time, but it's a way in which we want to stimulate research along that line. And from that standpoint, we need to give him a big old kudos because he has done a tremendous job of this.
Yes. It's a fantastic article, and if this is of interest to you, it's worth the time to take to give it a read. But we just wanted to bring a synopsis to you in a way that was easy and convenient, and just kind of a wrap of what you'll find contained in that article.
Good conclusion. Reduce the incidence of BRON while protecting the skeleton of the osteoporotic patient. That's what we want to do, and we want to stimulate research along that line.
So thank you for joining us today on the webinar covering bisphosphonate physiology update, and we look forward to seeing you again for another webinar on another topic. Have a great day.